Hi, everyone. I'm Dr. David Wahba. I'm one of the pain physicians in SCOE, and I would like to take this opportunity to explain a little bit about pain management and what we do and how we can help our patients. So a little bit about me. My name is David Wahba. I am initially from Egypt. I moved to the States in '97, here to California. I went to UCLA for undergraduate. Then I moved to Chicago, where I attended Northwestern Medical School, graduated from there, and then joined Cook County Hospital for my residency, and then my fellowship for training in interventional pain management. After that, I joined a group for a year in Illinois. Then I moved to California, where I have been here since 2016. Most of the stuff that I do is in this slide. I specialize in interventional pain. I do mostly spine. However, I do some pain, joints pain, such as knees and hips and elbows. However, most of my work is done on the spine. This has a list of the conditions that I treat and a list of the procedures and treatments that I do. So we can start with talking about what is pain. Pain is basically your way or your body's way to tell the brain that the body is in danger. For example, if you put your hand on a stove, on a hot stove, your nerves in your fingers feel the heat and then tells the brain that this is not normal, this is not something that we or the body can continue having, so you pull your hand out. This happens in a matter of milliseconds. And it is a learning curve. The first time a kid put his or her hand on a stove, they learn that, and then you have that memory that you don't do that again. That happens with a lot of things, with a lot of things or a lot of pain signals. Pain is also affected by your emotional factors, your mental health, your what we call pain tolerance. So what I, for example, call a pain level of 5 out of 10, someone else might call a pain 2 out of 10, and someone else might call a pain 9 out of 10. It's not an objective finding. It's mostly a subjective finding. Your temperature you have a temperature of 99 degrees. It will be 99 in California or in Alaska. It's not going to change. But with pain, it's something that you express, and depending on your experience and what you as a patient can handle. There are different types of pain, and under each one of those conditions or types that I listed, there are other subtypes. So there's chronic pain, there's acute pain, there's radicular pain, and there are different types of radicular pain. There's axial pain and different types of axial pain, and then there's also arthritic pain, and there are different types of arthritic pain. So these are the major types of pain that we deal with in an interventional pain practice. But under each one of them, there is other different types that can be addressed also. So we'll start with what is chronic pain. Chronic pain is a condition or a pain condition that you have for more than 6 months. It usually starts with acute pain that can continue to progress to more than 6 months, and then you call it chronic pain. And that's the majority of patients in my practice, patients who have been suffering with pain for more than 6 months, and they've had treatments that were directed by their primary care physician or by other pain physician, and then they usually come into my practice and we address their chronic conditions and we work with that, and we try to help them with these conditions. Acute pain, on the other hand, is a pain that is less than 6 months, and that is usually due to a specific incident or a specific condition, a specific cause, such as surgery or trauma or a car accident, a fractured bone, a broken bone, or an injury to a ligament, like some of these things. Or like I said, after surgery, you do have pain. So these are the things that can cause acute pain. Another type of pain is radicular pain, and that's pain that is caused by nerve. It's mostly nerve pain, and that can be due to compression of the nerve, can be due to inflammation to the nerve, it can be due to injury to a nerve. One of the conditions that I see most commonly in my practice is radicular symptoms due to a disc bulge or a disc disease that could happen in the lower back or in the neck or in the thoracic spine, the middle of the back. and that can cause pain in the distribution of that nerve. Being most common is what we call the sciatic nerve, which is the L5 nerve, or the last nerve in your lumbar spine. And if that is compressed, or if that nerve is irritated, you get a lot of pain that can be burning, pulsating, sharp pain in a distribution of that nerve. And that can also, if it progresses or if it lasts for a prolonged period of time without being addressed or without being treated, you can cause muscle damage or muscle weakness. You can also cause loss of reflexes, and it can turn into a permanent condition. Some of the treatments that can be used for ridiculous symptoms are medications, physical therapy, acupuncture, chiropractic, injections that I do, and that's where most of my practice is, epidural injection, nerve blocks, that kind of treatment. And if all these fail, the patient can be evaluated by a surgeon, a spine surgeon, for possible spine surgery. Another type of pain that is very common in my practice is axial pain. Axial pain is dull pressure pain. However, it can also cause some sharp pain or burning sensation. This can be continuous or it can be intermittent depending on the position that the patient is at and what kind of activity they're doing, and that can cause increase in the pain or reduction in the pain. Axial pain is mostly found in the neck or the lower back. However, it's found more in the lower back because of the pressure on the disc or the pressure on the joints. The more on the top of the joint, the more prominent the pain can be, or the more severe the pain can be. So in the neck, it's only the weight of the head, versus in the lower back, it's the weight of the whole body up until almost the waist. And that's the majority of, or almost 70% of your weight. So that can be causing that pain. Another type of pain that is also prominent or very common in public, and I see a lot of it in my practice, is arthritic pain. And that is usually found in specific joints, like the hip, the knee, the ankle, the hands, and it can also be found in the joints in the spine, what we call the facet joints. Arthritis is usually caused by destruction of the cartilage, or mostly osteoarthritis is caused by destruction of the cartilage, which is in between the bone joints. Anytime you have two bones coming close to each other, such as in your knee or your hip or your spine in the facet joints, you have cartilage in there that helps lubricate the area and help prevent friction between bones. When this layer is damaged, what happens is that you get a lot of friction, and that can cause inflammation, and that can cause pain. So that's the osteoarthritis. The other common type of arthritis is rheumatoid arthritis, which is an autoimmune disease where your body produces antibodies that attack the joint and cause damage to the joint and can cause the pain. I mostly treat osteoarthritis. Rheumatoid arthritis is mostly treated by rheumatology or rheumatologist. And when I see a patient of that kind of condition, I normally refer them to the rheumatologist to address that kind of treatment or that kind of condition. Most of the treatment for arthritis is directed towards reduction of symptoms and improve quality of life and change lifestyle. So causes of pain. What causes pain? Like we said, injury, repetitive injuries, lifestyle, inadequate treatment of acute pain. When we say repetitive injury, for example, I have police officers that are in my practice with a lot of back pain simply because of the belt that they're wearing while they're in duty, weights 30, 40, sometimes even more, 30, 40 pounds, or sometimes even more, and that affects their back. Patients who do a lot of desk work where they're looking down a lot can have neck pain. A lot of other patients who are in manual labor, they have a lot of neck or lower back pain. So depending on the lifestyle and how you carry on with your work and how you carry on with your life, you can cause pain in your lower back or your neck or your joints. And we're all guilty of picking up stuff or heavy lifting without the appropriate equipment or without the appropriate position. So that also affects the pain. One of the other things that can be affecting your pain is the amount, or can be affected by your pain also, is the psychological effect of pain or psychological effect on pain. A lot of patients that have been in chronic pain patients have been in pain for a while. They have depression. There's anger associated with it. There's anxiety. There's mistrust in the treatment that they're getting because they're not getting the appropriate treatment, or sometimes they're being accused that the pain is not that significant, that it does not require that treatment. And again, that happens with physicians or with treatment that a patient can get from medical personnel that is not trained in interventional pain or pain management. That could happen, and that could create that mistrust with the medical staff. And that's why one of the main component, or the main things that I explain to my patients the first time that I see them is that this is not a one thing that we do. This is not one-way treatment. It's not just medication. It's not just lifestyle modification. It's not just injections. It's a multifactorial treatment. We decide on a plan. We follow guidelines for pain management, but each patient is different. Each patient condition is different. Each patient presentation is different. And my job or my goal is to find what is the best plan for you within the guidelines. So we sit down, we go over your presentation, your conditions, your injuries, your imaging, what has been done before, and we come up with a plan. And the plan could be just physical therapy. The plan could include physical therapy and medication, could include physical therapy, medication, lifestyle modifications. There are different styles and different things that we can do. And I get that question sometimes from patients, like, well, I have the same condition that so-and-so my neighbor has, and they got this treatment. Well, in your eyes, it might be the same, but when I look at the patient, I look at the patient as a whole. I look at the imaging, the plan, the presentation, the symptoms, everything that's being presented to me. And that's why the more information I get from the patient, the better my plan will be, and the more inclusive my plan will be. I'm going to touch on some of the statistics that we have for pain patients, or for the prevalence of pain in the United States. I'm not going to spend too much time on that, but it shows how prevalent and how severe of a problem pain management or pain conditions are in the United States. In the United States, the pain or chronic pain affects more patients than heart disease, diabetes, and cancer patients combined. And these are three of the most common conditions that we see in the United States these days. Pain presentation is more than all three of them combined. About 126 million people are having some sort of pain condition that is prevalent within the last 3 months. 4 million adults have a lot of pain. And again, what is a lot of pain is different from me to you to someone else. And 3 million adults suffer from pain on a daily basis. Depending on the report that you see, there are anywhere from 50 to 100 million people in the United States that have chronic pain or have some sort of pain. About 26% have chronic pain and have pain that are more prevalent within the last 24 hours, have pain within the last 24 hours. The most common types of pain are low back pain, headaches, and neck pain. Neck pain and headache can be combined together in one category, because neck pain can cause headaches and headaches can cause neck pain. So they can cause each other. So we can combine them together in the same category. The cost of pain or pain management is staggering in the United States. It's about $560 to $635 billion that are being spent annually on pain management, whether it's injections, medications, hospitalizations, lost income, lost productivity in businesses. All these things combined together add to that staggering number. And if memory serves me right, that's about how much the United States spent on the defense. So that, or probably a little more. So we're more expensive than the Pentagon. People in the US spend about $50 billion on back pain alone. And that just medications and injections and surgeries. So that's a little bit more statistics. It's with low back pain, it's the #1 cause of disability, whether it's temporary disability or permanent disability or loss of wages or loss of work time in the world, and not just in the United States. It's a global problem. We have about 6 million people in the United States that have chronic low back pain. And again, it goes back to the point that low back pain, or pain in general, not just low back pain, it can affect the mental status and the mental health of the patient. I lost count of how many times patients come to me and say, you know, just the pain is not just affecting me, it's affecting my family. It's affecting my relation with my wife or with my husband. It's affecting my ability to enjoy events with my kids. I can't go to basketball games or baseball games with my kids because I can't sit there. I can't do the whole thing. And that affects the personal life of the patients. About 28% of adults with lower back pain report limited activity due to the pain. Lower back pain patients are more likely to be in poor health, whether it's physical health or mental health. And it's one of the most common causes, like we said, to missing work and lost productivity. So those were the statistics, and they're very severe. Like, these statistics show that it is. I sometimes call it a pandemic in the United States, pain pandemic, and it's an ongoing pandemic. These are the treatments that we have for pain or for chronic pain. We start with the most conservative treatment, or at least I like to start with the most conservative treatment. Physical therapy, lifestyle changes. And if those don't work, we start introducing medications. And the medications can be non-steroidals, muscle relaxants, nerve modulating medications. On a limited use, we use opioids. Other treatments include injections, such as epidural injections, nerve blocks, facet injections. There is a whole spectrum of injections that we can use that help with pain. And then if all that fails, then we move on to a more advanced treatments, including pain pumps, spinal cord stimulators, and last resort is surgery. And I've been fortunate enough that all the surgeons that I work with here in SCOE, they believe that surgery should be the last resort that we use. So, however, it is an option that's available if everything else fails. So with medication, we start with non-opioid medication, like I said, aspirin, acetaminophen, NSAIDs. And then we move on to some other medications, such as nerve modulator medications, muscle relaxants, other adjuvant medications. This is alongside physical therapy, chiropractic treatment, acupuncture, lifestyle modification. If all this fails, we start introducing some narcotic medications, such as tramadol. We start with the weakest one, then low dose narco, then oxycodone, then we go on to higher medication. In my practice, I basically never prescribe morphine or fentanyl outside of the hospital, simply because these medications are strong respiratory depressants. So if we prescribe them to a patient, there is a chance that something might happen when the patient is at home. I only prescribe them during or in a monitored environment, such as the hospital, where the patient is hooked to monitors that they're monitoring the patient all the time. There are nurses, there are physicians. So if something happened, the patient will be addressed, or the condition will be addressed right away. So prescription pain medication. This is a pandemic within a pandemic in the United States. We had over 40,000 deaths from overdosage from opioid in 2020. We have over 2 million people that are having some sort of abuse disorder involving prescription opioids. And this is a continuum. This is not just one point. There are patients who are functional, and there are patients who cannot function at all without the medications, and they get dependent on them. And that's a problem that can be a problem for their life, for their work, for their social life, for whole other things. There are overdose death. There are violent crimes. There are burglary of pharmacies and houses, and like because people need, they're trying to get money or something to buy these medications, or they end up buying, like they're being bought on the streets. So that's all. This is part of the pandemic that we're facing right now. So this is a statement from the American Society of Interventional Pain Physicians, and it states prescription pain pills should never be frontline treatment for chronic pain. By their very nature, they can help with acute cases of pain like fracture or post-surgery, but do not work for patients on a long-term basis. What happened when patients get prescription narcotic medication, they start to get used to them, they start to get dependent on them. And then you start the patient on very low dose, but then if the cause of the problem is not addressed, the cause of the problem is not solved, the patient just becomes dependent on these medication, and they start having more and more medication. So my goal is to figure out what is the problem, solve the problem, so that you don't have you don't have to depend on these medications. The narcotic medication are designed for short-term use, for short-term conditions, such as after surgery or cancer patients, and mostly terminal cancer patients. Any use other than that can be problematic. However, there was a period of time in the United States where there was the use of narcotic medications were very liberal, and so we see the byproduct of that. We see a lot of patients who are dependent on these medications, and the goal of patients, or the goal of pain management physicians at this time, to go to reverse that, to go back to not using that as much. So the long-term evidence to support chronic use of opioids is lacking, to say the least, versus the proven side effects or the proven dangers of using long-term narcotic use, such as tolerance, side effects from the medications, addiction, the stigma of using opioids itself, the limitations on work or limitations on joining activities with other family members or other friends because of using of these medications. All these things that affect the usage of narcotic medication, or affected by the usage of narcotic medications. The major risk of opioids is just, like I said, abuse and dependency, the main things, and that we see them in the wrong usage of narcotic medication. It is not designed for long-term use. It's designed for short-term use, and as an aid until the actual problem gets solved. Unless we solve the problem, then we're not doing the correct job. So alternatives to the medication, or the narcotic medication. One is living with pain, which is not acceptable. Interventional procedures, which what I do. Surgical intervention, which what we do when the patient fail the conservative treatment, we refer them to surgical intervention. And other technology, such as spinal cord stimulator and pain pumps, which I do when the more conservative treatments, such as injections, fail. So I'm gonna show some of the procedures that I do in my practice. This is not a full list. This is just a little bit the more common procedures that I do. But there are a lot more procedures that are not covered in this presentation, but will be that, like, if a patient has questions or if a patient has certain condition, we can definitely address that. So the first one is an interlaminar epidural, which is the most common procedure that we do, and this is a lumbar interlaminar epidural. This can be done for the lower back, for the lumbar, for the thoracic, which is the middle back, and it can be done for the cervical. And that is just in one needle goes into the epidural space and put in the medication, and we take the needle out. The whole procedure takes about 2 to 3 minutes. It's very quick, very safe. This is a transfemoral epidural, which we use for patients who have low back pain or neck pain, but there are more towards one side. In this case, it's a patient that has an L5S1 disc, that's causing L5 radiculopathy on the right side. So if the patient has pain on the just one side, we direct the medication towards that side specifically, versus in the middle or versus in the epidural space as a whole. This is a medial branch block, which is directed for the facet joint. The facet joint is what we talked about earlier in the spine, where the vertebra comes close to each other, and you get arthritis in that area. This is directed to numb or reduce the inflammation around the nerve that is causing sensation in that joint. Another injection is the facet joint, which is another type of blocking the nerves in the facet joint, but this one is basically done in the joint itself, not just the nerve. And that injection you usually do for spine surgeons when they're planning to do a fusion procedure. They usually request that kind of injection versus the medial branch. This is a radiofrequency ablation, where this is the second step after the facet joint or the medial branch. If the patient is not a surgical candidate or they don't want to have surgery at the time, what we do is that once we do the facet joint injection or the medial branch block and we get good results, but if it's short-lived, then we move on to the radiofrequency, which is the same procedure where we put in the needle and connect it to a heat generator that heats the needle to about 100 degrees, and we use it for about 90 seconds, and it damages the nerve endings, and that helps reduce the pain that you feel all the time. It is not if you hit your hand or your foot against the wall, you will feel that pain, but the pain that is consistent and continuously, that should be reduced using that procedure, and usually lasts anywhere from 3 to 9 months, and it can be repeated again because the nerves grow back. So we need to burn the nerve endings again. These are some of the procedures that we do in the surgery center on a day-to-day basis. But if these procedures don't help, then the next step is to do a more invasive procedure. One of the more invasive procedures are spinal cord stimulator. The spinal cord stimulator is a device that I place in the back, where it's 2 wires we place in the back and connect it to a battery, and that battery gives electric shocks in the spine. The electric shocks in the spine, you don't feel them. There are 2 types. I'll take that back. There are 2 types of stimulators. There is the traditional stimulator, which is a low frequency stimulator, and there is the high frequency stimulator, which with the low frequency stimulator, you get that tingling, buzzing sensation in the arms or the neck or the lower back or the legs, depending on where the leads are placed for what condition we're treating. The high frequency, it's a high frequency stimulation, so the spine feels that that effect, and it blocks the spine ability to send pain sensation to the brain, but you don't get that buzzing sensation or tingling sensation, which is, in my experience, I've now have moved exclusively to high frequency stimulation, simply because I've had patients before where after a few months of having the low frequency stimulation, they say that tingling sensation or buzzing sensation is more bothersome to them than the actual pain that they had the procedure for. So how does the spinal cord stimulator work? It works by, there are different theories of how it works. One of them is the gate control theory, which is what I explained, is that it numbs the spine to the pain sensation, so it doesn't send the continuous signals to the brain. Again, if you have a trauma, or if you hit your hand, or if you hit your foot, you will feel that pain. That is not going to prevent you from feeling the acute injury. Another theory is that endogenous opioids, which is endorphins that the body produce, and that helps reduce the pain sensation. And some thought that by using this, the stimulation, the continuous stimulation, it stimulates the body to produce these chemicals, and that reduces the body's ability to feel pain or continuously having pain. Other theories are GABA, which is a neurotransmitter that there's some thought that it helps with the pain control. Adenosine is another one, calcitonin gene-related peptides, nitric oxide. All these are chemicals that can help with, or they're thought to help with the pain control. Another one is that it helps control the pain that is caused by the sympathetic nervous system. There are two main systems in the body, 2 main nervous systems, in the body, which is the sympathetic and the parasympathetic. The sympathetic nervous system, there is a thought that it's control that is responsible for some or a major part of our pain sensation. One of the conditions that are being affected by that mainly is a condition called CRPS, complex regional pain syndrome, and it's a condition that I see a lot in my practice, and it's part of the radicular symptoms, radicular pain also. So the stimulator help reduce the pain that is caused by that sympathetic nervous system, and we use it to address conditions that like CRPS of the upper or the lower extremities. Indications for the stimulator, couple of the indications that are approved here in the United States are number 1 and 2 are failed back surgery. Patients who have back surgery and the mechanical problem like a disc bulge or facet disease or a tear in the disc, these are solved, but sometimes even after solving the mechanical problem, the actual nerve pain lingers after the surgery, and it doesn't get helped by the actual surgery that happened. So that's a condition that can be treated with spinal cord stimulator. The other one is the complex regional pain syndrome, which I just talked about a few minutes ago. Other conditions that are actually being used now in Europe, however, in the United States are not approved by the FDA yet, including intractable angina pectoris, which is chest pain, peripheral vascular disease, other conditions such as pancreatitis, chronic abdominal pain. These are conditions that, another one is phantom leg pain or phantom limb pain. After a patient has an amputation, they can still have pain in that area. So that's another condition that can be treated. These conditions are actually being used in Europe, but they're still not being approved here in the United States. Contraindications are pregnancy, life expectancy less than 1 year. However, this is a relative contraindication because it can be used for patients who have some conditions that, even though their life expectancy is less than a year. Malignancy, anticoagulation, patients who are on warfarin, Plavix, that kind of medication to thin their blood for one reason or another. However, this still is a relative contraindication. I have implanted patients with anticoagulation before safely. However, this has to be coordinated with the physician who is prescribing the anticoagulant, being it the cardiologist or a primary care physician. But I work with them in order to get this bridged so that we can do the procedure safely without causing any problems. These are the conditions that I was talking about: phantom limb pain, post-amputation, post-herpetic neuralgia, MS, spinal cord injury. All these applications are actually approved in Europe, but they're not approved here in the US yet. The studies are still being done, and I think we are very close to getting them approved, but it hasn't been done yet. We screen the patients before we do this kind of procedure because it's a more invasive procedure. The screening consists of MRIs, updated MRIs, psychological evaluation. With the psychological evaluation, I get asked the question a lot: is that, well, I don't have any side problems. Why am I getting that? We expect that patients who have been in chronic pain, like we said earlier, they have a little or a certain level of depression. We want to make sure that this depression level is acceptable, and we can implement this procedure or implement this treatment for them before we do it. And also because it helps us make sure that the patient comprehend what is the responsibility with that kind of a device. So in conclusion, pain management or chronic pain is a severe problem in the United States or in the westernized world. The number of patients is staggering. The condition is only getting worse, and we have to work on getting it reversed and getting the patients in a better position without giving medications or without doing treatments that might harm them in the long term. My advice to patients is that they need to see their patients once they have pain. You need to start looking at having these conditions looked at or being evaluated. I'm not saying that if you have a pain today, you run today, you are right away. But if you have a problem that has been, if your back is bothering you for a week or so, it wouldn't be a bad idea to have your primary care physician examine you first, and then at that time they can decide whether you need to see a specialist or is it just an acute event that will go by itself. But I don't recommend waiting weeks and months before you actually get treated or getting your condition examined. So with that, my talk is done. These are the locations that I see patients at, and Bakersfield and Valencia and Van Nuys, and these are the phone numbers that you can call to make an appointment with myself. Thank you so much.
Okay, now we're going to open this up with a question and answer portion of our program. We've got about 25 really good questions here, Dr. Wahba, so hold on to your stethoscope. I'm just going to read them off as they came in, and I'll let you feel free to answer. Doctor, I've been on gabapentin for neuropathy in my feet. It never helped. Should I try Lyrica or something else?
Well, first we need to know how much gabapentin you're using. You can take up to about 3,300 milligrams of gabapentin daily, and then that we'll see if that helps you or no. Lyrica is the same kind of or the same family of medication. Some patients have side effects with Lyrica, but not with gabapentin, and vice versa. If gabapentin, we get to a point where we get you to a level that is not helping, then we can switch to Lyrica.
Thank you. Doctor, can you address ketamine and methadone as pain management medicines?
So methadone is normally used for patients who had an addiction before, heroin addiction mainly. It can be used as a pain medication. However, it is a very I don't want to say dangerous, but it's a drug that needs a lot of monitoring because it's a synthetic opioid. It's not a natural opioid. So the effect on the body is different, and it's different than from one person to another. For example, one thing is that the half-life, which is the amount of time it takes for the body to get rid of half of the medication, can be anywhere from 12 hours to 111 days, depending on the patient and on your metabolism of the chemicals. Also, it does affect the cardiac system, the heart. It can prolong something called the PR interval, which is how fast your heart beats, and it can slow it down dangerously. So when patients are on methadone, initially, they have to get an EKG almost every week for a period of anywhere from 6 weeks to 12 weeks. And then they also have to continuously or regularly get EKGs and have that monitored almost every 3 months. Ketamine is it's a sedative. It can be used for anesthesia, but it can also be used to treat some pain conditions such as CRPS. There's something called a ketamine infusion with a specific protocol that can be used for CRPS and also for chronic pain.
Thank you. How do you know if osteoarthritis or rheumatoid arthritis? I've been diagnosed with osteoarthritis. Could it be misdiagnosed and really be rheumatoid arthritis?
With rheumatoid arthritis, there are blood tests that are being done because we test for the antibodies. Osteoarthritis is usually a diagnosis of exclusion or diagnosis based on the presentation of the patient, and it also depends on imaging. You look at MRIs, you look at CT scan, you look at X-rays, and you see the damaged cartilage or the decreased disc space or decreased joint space, and that's how we diagnose osteoarthritis.
Excellent. Doctor, how can you make sure you're getting appropriate treatment? What should you look for in a pain management specialist?
Well, that's a a very loaded question, but you can actually, well, if there are results from the treatment, then you are getting the appropriate treatment. If there are no results, then probably you're not getting the appropriate treatment. But with that, there's a caveat to that, is that 90% of patients, they don't have only one pain generator. Pain generator is what we call, or the cause of your pain. So sometimes it's, I have patients who have, for example, axial low back pain and radicular pain and arthritic pain. We do a certain injection or a certain treatment, and their radicular pain is great, but they still have the axial pain. Or we do the axial pain first, and they still have the radicular pain. And also another thing is that the brain is designed to pick and focus on the thing that is bothering you the most, or that is most more prevalent. So once you control that pain generator, other things start to come up. So you might think, okay, I'm not getting better, but in reality, you are getting better, but on the one area that we focused on.
Thank you. What do you think, doctor, about acupuncture? What is the success rate that you've seen with that?
Acupuncture is a very good adjuvant treatment that we use with pain management. However, it also, you have to be very careful where you're getting it. You need someone who know what they're doing. You need someone who's actually well trained. Where I trained in Cook County, we had an acupuncturist that has been doing it for 25 years. He actually used to, or still does, go to China every year and get a course for 2 weeks to update his knowledge. And we had great success with him. So it depends on where you go and who's doing the acupuncture, but it can be very helpful.
Super. Can circulating issues in one of your legs be related to lower back pain?
Circulating issues. I mean, if I understand the question correctly, I mean, it means blood supply, blood flow to the leg.
Yes.
Yes, and yes, that can cause some pain, because you think of the body as one unit with different compartments. If you have leg pain due to circulation, you're not walking properly, so that can affect your back. If you have, for example, a knee pain, you're not walking properly, that can affect your back. If you have back pain and you're trying to baby that, or trying to compensate for that, that can affect your hip or knee. So it's all connected to each other.
Thank you. What are alternatives to antidepressants for treating chronic back pain? And why would someone use an antidepressant for treating chronic pain?
So antidepressant is one of those medications that we use. They're not first-line medication, but they're used alongside NSAIDs or gabapentin or nerve modulating medications. And the exact mechanism of why, it's not really fully understood yet. But one of the reasons, or one of the mechanisms that we think it works on, is that it works on altering some of the neurotransmitters that are responsible for pain, such as GABA or adenosine, and they work on those transmitters, and they can help with the pain.
Thank you. Can an epidural cause future back problems and or headaches, or is this a myth?
So yes, it can cause headaches. When we're doing an epidural, what we trying to reach is an area called the epidural space, which is between your ligaments and your spinal cord. There is an area called, or there is a layer in between the spinal cord and the epidural space called the dura. If we puncture the dura, what we call CSF will leak out of that area, and that can cause pain. That can cause headache, because the CSF is a fluid that runs through the skull and the spine, and it carries the brain. It keeps the brain floating. So if the CSF is leaking, not enough of it, the brain will sink. And when the brain sinks, that causes headaches. So yes, it can cause headache. However, that is not a long-term condition that can be treated with something called a blood patch or NSAIDs and anti-inflammatories. As for causing pain, yes, one of the things that could happen, it can cause pain. It can aggravate the condition that you come in for initially. Very unlikely, but it can happen.
And regarding epidurals, what are the risk factors for epidurals?
The risks for epidurals are infection, bleeding, nerve damage, spinal cord injury, reaction to medication, paralysis, seizures, all these things. But epidurals and interventional pain injections are very safe procedures. They're being done every day, thousands of them. We do them, I personally do them all with X-ray guidance, so I know exactly where my needle is going. I know exactly how deep it is going, and that's how I keep it as safe as much as possible.
Okay, here's another one. Can spine stimulators cause paralysis?
I haven't heard of that, but if it is placed incorrectly and if in the procedure itself, if it's placed incorrectly and if it hits the spine multiple times, then yes, you can cause damage to the spine that can cause paralysis. But that's again why these procedures are done with X-ray guidance, so that we know exactly where the needle is going, how deep the needle is going, where the leads are going, and whether they are close to the spine or they're not, and that's how we do them safely.
Excellent. And speaking about those stimulator implants, is this something that is done in a ambulatory surgery center or hospital?
99% they're done in the ambulatory surgery center. Very rarely we do it in the hospital unless the patient, it's not safe for the patient to be. If the patient have a lot of other medical issues that we don't feel safe that they'll be done in a surgery center, then we do them in the hospital. But I probably have done like 3 or 4 in my entire career in the surgery in the hospital.
The hospital. Okay, thanks. Let's stick on stimulators. Can you take a stimulator out? And are there any restrictions for stimulator implants? Like, can I swim or hike, bicycle, drive, etc.?
Yes. So the first part, yes, you can take it out. If you decide after a few years of having it that you don't want it anymore, you don't need it anymore, then yes, we can take it out. It's permanent implant in the sense that is inside of the body, not outside, but it's completely reversible. So that part of the question. The restrictions in the long term, no. In the initial phase after the implant, the first 6 to 8 weeks, I ask the patients not to do a lot of extraneous activity, not a lot of bending, not a lot of twisting, because the leads, we suture the leads inside, but they still can move. So we try to avoid those movements and avoid these certain positions, so avoid migration of the leads. However, even if the migration of the leads happen, we do have 2 leads in there. Each lead has 8 contacts, so you have 16 contacts in there. We only need 2 or 3 contacts. So if they move, what will happen is that we have the patients come in, we take X-rays. For example, like the patient is doing great, and all of a sudden they lose the benefit of the stimulator. They're not getting any more pain relief. So what happened is that we think that, okay, that the leads might have moved. We bring the patient in, we do X-rays. Once we do X-rays, we see where the leads are now compared to the previous X-rays, and then we map it. And then based on the mapping, we move from lead 1 contact 4 to lead 2 contact 5, whatever the new contact that's in the right position.
Thank you. Switching topics, what is your opinion of products containing CBD in relation to the treatment of pain? And what about products containing THC? So
products that contain CBD, I don't prescribe any of them. That's number one. Number two, I advise the patient to think about it very carefully before they start one of these products. 3, products that have CBD in it, I don't mind it if the patient is on that while they're under my care, as long as they are not asking me to prescribe it for them. However, THC, I don't allow patients to be on it at all, because that's the part that gives the euphoria, and that's the part that can be addictive. So I don't allow patients to be on that.
Thank you. Let's see here. Was a long one. What are other alternatives for anti-inflammatory medicines like NSAIDs, especially if you have an NSAID allergy?
So depending on the condition that the patient is presenting with, there are nerve modulating medications, there are muscle relaxants, there is Tylenol. These are the medications other than opioids. And then there are opioids that can be used if we need to. And then there are the procedures, interventional procedures.
Thank you. I got epidural injections years ago. Can I get epidural injections again?
Yeah, you can get up to 4 injections a year. And the number 4 is a consensus by pain physicians. There is not really strong scientific data behind that. We know that the steroids have side effects. So we're trying to find the number of injections that help the patient, but without getting too much side effects. And the number that we kind of agreed on is about 3 years. I'm sorry, 3 months in between injections. But again, that is not set in stone. That can be changed depending on the treatment plan. And that's why, like at the beginning, what I said is that everyone is different. Even though the condition or the presentation might be the same, or might look the same or sound the same to the patient, when I'm listening to you, when I'm talking to you, when I'm evaluating all your presentation and your MRI and all the treatments that you have before, my plan for person A might be different than person B, might be different than person C. Everyone is different.
Thank you. Just a couple more here. Are injections and stimulators only to treat the back? I've had pain in my hands, knees, hips, and feet for years.
No, there are injections for the joints, for all the joints that you mentioned, depending on why you have pain in that area. That injections can help, or it might need to be surgically addressed. And a stimulator might be also of help, but again, it all depends on what is the problem that we're dealing with. Any treatment, whether it's in pain management or any other field of medicine, can be great and can be detrimental. Can be great when it's used for the correct diagnosis and the correct way, and it can be detrimental if it's used for the wrong condition.
Thank you. Doctor, are you aware or looking into any newer treatments or trials for chronic pain that you find promising?
There is a new procedure called Vertiflex that I'm planning to introduce to my practice, and it does help with some pain conditions like lower back pain conditions. That's the newest one that I'm aware of. There's something also called intercept procedure, which is similar to radiofrequency, but for a different type of pain. But for the time being, or for the time that we're at right now, I do believe that the spinal cord stimulator is one of the conditions that, or one of the treatments that is the top of the line at this point. Again, for certain conditions.
Switching back to injections, there was a lot of questions about the epidurals. Do I need to get an MRI before I get an injection?
I recommend getting an MRI. Actually, I have to have an MRI before an injection, simply, or a CT scan. Some patients cannot get an MRI, so a CT scan simply because I want to know what I'm dealing with, whether is the injection even warranted before we do it, or am I going to cause more damage by doing an injection?
Another question here is pain relief from an epidural or a medial branch block or the other injection types you've discussed. Is the pain relief immediate? And how long after the injection will I have relief from my pain?
So that's also dependent on the patient. Some patients get immediate pain relief right away, and some patients, it can take them anywhere from 3 to 4 weeks before they get actual relief. The average is about 7 to 10 days before you start getting relief from the procedure.
Okay. Let me see here. There was another one about sorry.
No.
I'm just looking them all through. I'm trying to read some of these down here. The epidurals are covered by Medicare. And what about the spinal stimulators? Are they covered by insurance?
Yes, all these treatments are covered by insurance, and we have a full department that goes over that and make sure that the patients, the treatments are approved by the insurance before we do them.
Back to the medications. Can muscle relaxers help with pinched nerves?
One of the conditions or one of the byproducts of a pinched nerve is that the muscles can be irritated. And when they're irritated, they can spasm. And so the muscle relaxant will help with that. So it will help with some of the pain, but it's not going to solve the root cause of the pain.
Okay. Is it possible to have a successful trial for a spinal cord stimulator and have the implant fail?
That is possible. Very unlikely, but it is possible.
Okay. I'm familiar with joint pain, but recently have experienced pain in both an arm and a leg between the joints, on the fibula and also on the radius. Is this the kind of thing that I should come in for a consultation with you or a neurologist, or what type of specialist to identify the joint pain?
I would have to look at I would have to see you to decide whether it's something that I can help you with or no. So I can't really answer that. I would say that yes, you can come see me, and then if it's something that within the scope of my practice or something that I feel comfortable treating, I will treat it. If not, I will refer you to someone else.
For pain relief, what about creams and topical ointments? How do they work?
For arthritic pain, it does work. I've had success with diclofenac cream, Voltaren gel, lidocaine patches, that kind of sort of thing. It does help with the joint pains.
And doctor, can you spell the name of the new procedure that you were talking about that seemed promising and that you were looking to add to your practice? Was it Intracept?
There are two. There's the Intracept, which is a form of radiofrequency, and there is the Vertiflex, which is VERTEFLEX. It's a procedure where we put in, like, for lack of a better term, a hook in between the vertebra and kind of expand it, so the pressure on the nerves or the vertebra, instead of being compressed to each other, they'll go up in space and in distance, and that gives the nerve a little bit of breathing room.
Doctor, can you talk about the artificial discs your practice is surgically inserting? How safe are they, and do they work?
That is actually not a question for me, because I don't do these procedures. These are done by orthopedic spine surgeons. So that would be something that you have to talk to an orthopedic surgeon about.
Here's one that goes back to a pain medicine. Does taking gabapentin for a long time, say over 3 years, could this potentially cause Alzheimer's disease?
I don't think so. I've never heard of that. One of the side effects of gabapentin is that it might make you drowsy, but I haven't heard of memory loss or Alzheimer's like conditions.
A couple more here. I had a microdiscectomy 3 years ago. Ever since then, I've been relegated to sitting constantly from my job. My back pain has returned. Could this be related to a particular surgery, or could it be a different issue? Would you recommend an MRI or PT physical therapy first?
To answer the first part of the question, yes, it could be either. It could be recurrence of the nerve or the disc that you had the surgery on. It could be something different. And yes, you need an MRI to examine that and see what's going on.
Okay. Here's one. I had a rotator cuff surgery late December as I twisted my hand, wrist, and elbow to the point of my tear, but I am still having trouble with my wrist, hand, neck, and elbow. I just had a nurse study on my whole arm. Now my hand and wrist really hurt, and there's a bulge in my wrist under the thumb. Should I see my doctor, and what type of doctor?
I would start with if the bulge and that increased pain happened after the nerve conduction study, then I would see the physician who did the nerve conduction study. If not, I would see the primary care physician, but someone needs to take a look at it and decide where to go from there. Whether you need to see a spine surgeon, or you need to see a hand surgeon. Do you need to see someone like me do interventional procedures? And then we can go from there.
All right, just about a couple more and then we're going to wrap up. Doctor, how do you take a person off a fentanyl patch?
So that has to be, depending on how long the person have been on it, but it has to be done gradually. So depending on what's the dosage that the patient has been on, I usually would go 25% at a time every couple of months, and then to see how the patient does.
Fair enough. I'm going to finish off with this one. What is the wait time to get in to see you, Dr. Wahba? What if you are a patient of another provider at SCOE?
That's a very good question, which I've been blessed with a problem, which is that I'm very busy, thank God. But I don't know the exact length of it, but I'm very, I try as much as possible to accommodate any patient and every patient who come in. But at the same time, there is a limit to how many patients they can see safely in a day. I can't tell you exactly how long is the wait. But one of the other things that I do is that I do telemedicine, which is video visits, and I do those before clinic hours or after hours, so that expands the window of when the patient can see me. And we can start with one of those visits, and at that point, it would be easier to get you back in as a return or as a follow-up patient. But those are one of the things that we can do.
Super. I'm going to go with these three more because they're real interesting, I believe, for you. L4 and L5 moderate degeneration. What is the best treatment? Would I see a pain management specialist or a spinal surgeon?
Well, I would start with the interventional pain. I'm a little biased, but the reason for that is 99% of surgeons will not operate on someone unless they have tried conservative treatment first. The only time where surgeons that will operate on a patient right away is that if the patient has like emergency motor function loss or sensory loss, or patient lose control of their bowel or bladder. These are things that, okay, we cannot wait for conservative treatment. This needs to be done now. But if it's a chronic condition, would like to see more conservative treatment done first. And again, that also is required by the insurance. For the insurance to cover your surgery or cover your treatment, they want to see that the more conservative treatments are done first.
Okay. Waiting to hear this one. I'm scheduled for an epidural injection on Friday, this Friday. I've had an epidural before about 10 years ago. I also have knee arthritis and wondering if I have a second epidural that Dr. Wahba can and will offer multiple injections, both knees and back, at the same time.
I don't do that for a very simple reason. I don't want to overload your system with steroids. And at the same time, I don't want to give you a portion of the steroid in each area, because this way you're not going to get the best benefit on all three of them. So no, I would not do the back and the knees at the same time. And the knees do not need to be done in the surgery center. Depending on what kind of injection for the knee, they can be done in the office.
Wonderful. Well, I know we still got a couple more questions that we'll try to address after the seminar here, and I will reach out to you to do that. I'm going to close now with Dr. Wahba and the question and answer portion, and maybe we could put the slide up of how to reach Dr. Wahba in the future, our practice in Bakersfield, Valencia, and Van Nuys. Want to thank everybody for attending the program tonight. I think there was a lot of great material and information covered. This program was recorded and will be posted soon on the SCOE website under the news and events. Thank you for attending tonight. We appreciate your cooperation and questions and attendance. Good evening.